Production funding for Behind the Headlines is made possible in part by the WKNO Production Fund, the WKNO Endowment Fund, and by viewers like you. Thank you.
The President and CEO of St. Jude Children's Research Hospital, Dr. James Downing, tonight on Behind the Headlines. I'm Eric Barnes with the Daily Memphian. Thanks for joining us as we continue to do the show remotely. I am joined today by Dr. James Downing, President and CEO of St. Jude Children's Research Hospital. Dr. Downing, thanks for joining us.
Well, thanks for having me. It's a pleasure being here.
Along with Bill Dries, reporter with the Daily Memphian. I will start with the question I think many people have, that how do you keep people safe within St. Jude? Be it patients, be it staff. I mean, let's start with maybe the staff and then we'll get to the patients. How do you keep everyone safe and continue to do the work that you do?
You know, it's been the challenge since day one of the pandemic. You know, back in December, January, we started hearing about the virus coming out of China. We started hearing about spread, you know, from human to human. And we began to worry, you know, was it going to come? Obviously, in March, it came to the United States in a big way. And we, as an organization, really had sort of a unique challenge. You know, many hospitals, they were worried about treating patients with COVID-19. For us, the goal was really to keep it off campus. You know, how do we set up a mechanism to limit the entry of that virus onto our campus, because our patient population is so susceptible to infectious diseases. And so, you know, right from the start, back in March, we instituted emergency operating procedures. We set up an incident command center. We segregated the campus into a research side and a clinical side so that we limited the flow of employees across the campus. And, you know, we started limiting the number of employees that were on campus. We felt that by limiting employees to just essential employees that had to be on campus to do their job, we would prevent the spread of virus or of anybody bringing the virus, and we decrease the odds of that virus coming on campus. You know, then we had to start instituting testing. And so, you know, testing was a big deal to begin with, and it remains a big challenge in the United States. And so even back in March, we decided that we had to set up a test to be able to detect that virus in our workforce by ourselves. And we need to do that on a very routine basis on employees that were interacting with the patients. And so even with no symptoms, we had to be able to screen them and see, did they carry the virus or not? And so early on, we had to set that up across our institution, in our research labs and our clinical labs. We had to design our own tests. We had to get the reagents. We had to use our GMP facility to make some of those reagents. And we set up testing for the employees who were working on the clinical side. And that began with weekly testing every 4 days of those that were taking care of our patients. And, you know, then as the virus spread and we saw what happened in New York and we saw Louisiana and, you know, Washington State, it really became sort of another level. And so now we decided we had to test everybody on campus. And we really had to build a new testing laboratory. We had to import new equipment. We had to train new technologists to be able to run those tests. And we started testing every single employee every week. And so these are, you know, nasal swabs that then go into a nucleic acid-based test, the PCR-based test. And, you know, we have the capacity now to run about 6,000 tests a week on campus with turnaround times really less than 24 hours. And so every employee is screened once a week. If they have symptoms, they get screened in an off-site facility, but if they have no symptoms and they're coming to work, they get screened on our campus. The results are given back very quickly, and that allows us to know, are they infected or not? And if they are, we isolate them, and then we can contact trace very quickly and quarantine anybody who came in contact with that individual. And a second component of this mechanism to keep everybody safe is wearing masks and physical distancing and disinfecting surfaces. And, you know, so early on, everyone was wearing masks, and now every single employee wears a mask all the time, whenever they're in the institution. I'm sitting in my office by myself. It's a relatively large office. The second I walk out of the office, I don't walk out without my mask on.
Well, yeah.
We also have the physical distancing, which is very important. And so these elements, from testing, isolating, tracing, and quarantine, to wearing masks, to physical distancing, to disinfecting, these are the basic approaches that one has to take to really prevent the spread of that virus, or the entrance of the virus onto campus and the spread of virus. And I'm, really so proud that we have had no spread of virus from an employee to a patient, or from a patient or their family member to an employee. And so it wasn't that long.
Yeah, that's how many. Oh, I'm sorry. I was going to just to give people some sense of scale of that. I'm sorry to interrupt. The Zoom thing makes me impolite, and I apologize. But it's an important point. How many people? It's a huge staff. It's a lot of patients, and we'll get to this in a second. But the patients, many of them and their families, do come and go from campus because they are living off-site during treatment. So it's not simply that you, let alone your employees who don't obviously live on campus. So you're not in an NBA bubble. I mean, you have people coming in and out, so it's remarkable you've been able to do that. But give us a sense of the number of staff and the number of patients we're talking about.
It is very complex logistics to to manage the employee flow and the patient and family flow, and the testing and when they get tested. I would bet there's over 125 to 150 individuals that are actually just focused on managing our response to COVID-19. And so these include from security officers to people that clean the facility, to the nurses that are doing the swabbing, to the individuals that are doing the tracing of anybody who comes in contact with a positive employee, to people, going around the institution and making sure people pay attention to the rules and wear their mask and stay physically distanced. And, the bill for something like this, we're talking almost $20 million a year to be able to institute this kind of program across our institution. But it is so important because of the vulnerability of our patient population. And so it's really just essential that we focus on it, and spend the resources that are required to keep our employees safe and to keep our patients and families safe.
Let me go to Bill Dries and get him in here right now.
It's a very interesting point that you raised, Dr. Downing, and it kind of makes me wonder, what does the pandemic, do you think, say about the limits of our cutting edge research, which is by its nature theoretical, at least in the beginning, and the practical application of that research to something that is an everyday regimen or something that's a common feature of life?
I think, science has stood up in a big way during this pandemic. The emergence of viruses from remote parts of the world and the impingement of those viruses on human populations becomes reality as the human population grows. And so we've seen a number of coronaviruses come out of China over the last, decade and a half. None with the ability to spread like this coronavirus, but we have seen that before. And there's a lot of science known about coronaviruses, but when a virus emerges like this, it is, a major issue of public health and the culture of the country in which this is occurring. And so you see the responses being very different across the globe. And you see how rapidly this spread. And so that's not science's fault. That's modern life and the rapid transportation of people across the globe and the globalization of the economy, which allows that spread of people across the globe. And so it was predicted long ago that a pandemic would occur. It was predicted that one should strengthen their public health services to be able to combat a pandemic of this kind of nature, but most governments didn't heed those advice and didn't prepare their public health service to deal with it. And so then we see the rapid spread. Once you have the rapid spread, the tests were set up very quickly and very accurately, but the implementation of those tests were not done efficiently or effectively, and we still are not testing enough people across the United States to effectively manage this pandemic. That's, again, public policy and logistics, not the science. Then we look at the, how can we ever manage this pandemic now? It is spread. There's no way of getting rid of the virus. We can manage the virus through masks and through physical distancing and through reduced workforces and, stopping large gatherings. And we're seeing that have an effect across the United States. And we're seeing it have an effect in Memphis right now. But ultimately, it's going to be a vaccine or better treatment for those who come down with the disease. And science has really tackled that. You've seen, or at least heard of the progress that's being made on vaccines. It's a remarkable timeline to see this kind of progress. Vaccine trials, phase 2 trials have begun to be initiated. And so data will come from those. Those will be large number of volunteers that will participate in those trials. Those will tell us, does it show efficacy? What's that level of safety in a broader patient population or volunteer population? And, we could have vaccines available early in 2021. That's unheard of prior to this. And so that's the scientific community across the globe coming together and using whatever technology they can, from old technology to the most modern technology, to develop those vaccines. And so I have great hope that we will see vaccine candidates come out. And I think they will be effective to some level. Will they eliminate the disease and allow us to go back to our normal lives? I don't know. But I do think they will slow the spread of disease significantly, which will help us to get back to a new state of normal. So, I think as we look at the disease and we see the early death rates that were occurring in China, and then we look at the death rates in the United States and in other countries, we're learning how to better treat the disease. We're learning how to diagnose it earlier. We're learning how to manage those patients. And so we are seeing less deaths. That's also a good thing. But disease is spreading. It is out there, and we all need to remember that and do our part in trying to prevent the spread of disease. That's one of the things we're trying to impress upon the Memphis community is, our 5,000 employees are members of the Memphis community. They live in the Memphis community. That's where we all live. And where we've seen employees who have come down with the disease, they haven't caught it on campus. They've caught it in the Memphis community. And so wear a mask, pay attention to physical distancing. By you wearing a mask, you are decreasing the risk of a St. Jude caregiver catching that virus, and you're allowing them to continue to give the care they need to the children on this campus. So, wear that mask proudly, protect yourself, protect your family, but also protect us so that we can continue the life-saving work we have to do here at St. Jude.
Right. I know that St. Jude has protocols for research and things about contact, but in terms of testing the employees, testing people on the campus, was that something that you had to build from the ground up?
We did. When we, very early, the virus was sequenced. Everyone knew what the sequence is. Everyone knew how they could set up PCR-based assays. And early results from other institutions sort of said, here's an assay and it works and it has relatively high specificity and sensitivity. And so then the commercial labs got in and started selling kits. But the problem was early on, there weren't enough reagents to actually run the number of tests that we wanted to run. And so we had to develop the assay here on campus, generate the reagents here on campus. And so early on, we were running these in research laboratories to do screening of our employees, asymptomatic employees. And that those tests were, quality controlled against the commercial test, and we knew the accuracy and sensitivity, specificity of those tests. So we felt comfortable doing that, and we're able to isolate rare positive employees and keep them out of the workforce and isolate them and quarantine anybody that came in contact with them. Over time, as we went to the level of screening all employees and all patients and families, we wanted those run in our diagnostic lab. And so that really took building out that diagnostic lab, buying more hardware, more equipment to actually run those tests through commercial assays, setting up a redundancy so that if one company was running short on reagents, we wouldn't we wouldn't be stopped. We would have backup technology from a different company and be able to continue to run those assays. And so our capacity, is about 6,000 a week. I'll say the city in general is running about 10,000 a day. And so the city has a much larger capacity, but for us, that 6,000 a week means we can screen every single employee and patient and family every week.
Right. The reason I bring that up before we go back to Eric is that before this, I often heard people on both sides talk about a gap between public health and health care. And it seems like what you're saying is that as a result of this pandemic, as a result of this crisis, that gap is at least a little smaller.
Yeah, I think that's true. I mean, I think, a very good effort by the city and the county in the creation of the Memphis Shelby COVID Joint Task Force was a big element of that. It brought together all the healthcare systems in the city to get together, 2 times per week to essentially look at the healthcare infrastructure and the burden on the healthcare infrastructure, and look at the numbers from the public health sector on what the number of positivities were and where they were occurring. And, this allowed the medical institutions to talk to each other. It allowed, sort of developing strategies to increase testing and where they needed to be increased. So that has brought them together and has, worked really quite well here in Memphis to manage the response. And so that was the mayors doing that, the CEOs of the other hospitals from our institution. Greg Armstrong and Tommy Morey are part of that joint task force. And all of us are looking now at the same data, understanding what the impact is, knowing if the numbers are going up or down. Occasionally, there's a shortage in testing. And so we can provide some backup for certain healthcare institutions if they need it on a quick basis to allow them to better manage their beds as the numbers are increasing. So, it's really been good to see how well the different aspects of public health and the healthcare infrastructure of the city have come together.
Let me ask a question on those numbers and the task force. I mean, we have at the Daily Memphian and on the show, but the Daily Memphian, which is more of a daily, hourly kind of update, and all the news organizations, I think, have been very well intentioned in how they cover the numbers and the trends and what's going on. But we've all made some mistakes. And I'm curious, I ask this from you as a scientist, as a doctor in your role, what numbers do you look at every day? And what numbers are the most important that you think that the media should be most focused on? And those numbers maybe were different in April than they are now in August, right? So what are those numbers that we as the media should be most focused on, and readers and concerned citizens, and we should all be concerned?
Yeah, I mean, I don't know if you're seeing the same numbers I see, but, the daily number of positives, it really depends on who's reporting what test results. And so they sort of fluctuate. And the number of tests performed per day, they can fluctuate. What I pay attention to most is the number of hospitalizations, because that's a reflection of the severity of the disease and the true burden of the disease on the healthcare infrastructure, of the greater Memphis community. And, and that lags behind the positivity rate of individuals in the community. And, so that number is still going up. It's just starting to plateau, but that's the number that, one has to watch. If it doesn't plateau, we're in trouble. If it's starting to plateau, that's great. If it starts going down, that is even better. And, it's gone up quite a bit since, the opening of the city again. It is starting to look like number of cases and hospitalizations are starting to plateau as a result of the more recent shutting and the mask ordinance.
One thing, and we got a lot of feedback, and we got a fair amount of some amount of criticism, and a story came out that was released that there was a patient of Le Bonheur and St. Jude who died of an underlying condition but was COVID positive. You all are required by law, I think, given the pandemic and the situation, to release that. We made a mistake in terms of how we first wrote the story. I think we released it that the child had died from COVID, and the truth, the accurate story was that we corrected was that the child had died with COVID. But it came up in a lawsuit. It's a long story if people didn't read it, but it came up in a lawsuit. Alyssa Haushalter the county health department director mentioned a federal lawsuit that we'd had our first pediatric death with a person with COVID, not from COVID. Was that a complete mistake on the part of media, us included? I mean, that really this was just simply a reporting issue that you had to do, and there are lots and lots of asymptomatic people out there, or was it different?
It's not a horrible mistake, right? We're in a pandemic where we're learning things every day. There's uncertainty of the infection rate in the city. There's uncertainty about the severity of disease in the elderly versus other populations. For us from St. Jude, this was a patient who, had a very aggressive, unresponsive pediatric cancer. And, the chance for survival was very, very little. And, was infected with COVID-19, acquired that through the community, through their family, had minimal symptoms, I think, from COVID-19 and passed away as a result of the cancer. So it is a child that died of an unresponsive pediatric cancer, but they were infected with COVID-19. And so, in the bigger picture of following the numbers, it's one of those gray zones where it does have to be reported. She did have to state that a child had died of, with COVID-19, but it's not, a serious mistake by by yourself or by the publication. It's just in that somewhat gray area. We've had a very few number of patients who have been infected with COVID-19. All of those infected have caught it through the community or through direct family contact. If they're positive, we isolate them on campus, and we continue to give them their chemotherapy or radiation therapy, depending on the treatment approach that's being used. But as at a global level, we've set up a global observatory and resource center for COVID-19 and childhood cancer patients to really learn what is the impact of COVID-19 on pediatric cancer patients. And to date, I think it's almost 40 countries have participated, in that registry, registering over 750 children across the globe that have been infected with COVID-19 but have pediatric cancer. And our goal there is, what is the appropriate way to manage those patients? If they're overtly symptomatic, should one pause chemotherapy or radiation therapy and manage their acute reaction to COVID-19? If they develop multi-system inflammatory disease, what do you do? Or if they're asymptomatic, can you progress with their standard treatment without any risk to them? So we're rapidly learning the answer to those questions and developing consensus guidelines that then will guide the world. And so this is through our St. Jude Global and our Global Alliance program that's led by Carlos Rodriguez Galindo, and a great effort that we will learn rapidly from participating with everybody across the globe how best to treat those patients, no matter where they are in the world. A second level is from St. Jude, we're actually managing a registry in the United States that's for any child infected with COVID-19, not just pediatric cancer patients, but any child. And that's a large effort across the United States, but being coordinated from a faculty member here, bringing that data together and really looking at that data with the same goals as the global, and then merging the two together to see what is the best approach for children with COVID-19. But, let
me go back. Go
ahead.
With just a couple of minutes left, and again, apologies for the interruption. Really, I apologize. Let me go back to Bill with just a couple of minutes left. Get one more question from Bill.
Dr. Downing, talking about the global research that St. Jude has been doing, I was there for the opening of the latest research center, I think some 5 or 6 years ago. And I remember very distinctly that Marlo Thomas specifically talked about a day when chemotherapy is a thing of the past. Where is the hospital's research on that day?
The research is progressing at a rapid level. We didn't slow down in the pandemic. Childhood cancer is continuing to occur. We have tremendously strengthened the research infrastructure of the institution and recruited in many new leaders into the institution. We're gaining fundamental knowledge on the biology of cancer, on the genetic landscape of cancer, on the best ways to treat pediatric cancer. We're still, our cure rates are high, right? We're curing over 80% of the children with pediatric cancer, but that still means 1 in 5 who are diagnosed with pediatric cancer in the United States will die of their disease. And so a lot of our effort now is how to cure those children. How do we gain insights into how to provide them a chance for a cure, that 20% that are not getting cured right now. And then globally, over 80% die of their disease. And so we have our global program. How can we raise the cure rates globally so that children everywhere can have access to care? The elimination of chemotherapy is a long way off. We're developing better and better approaches to treat cancer, more targeted approaches that use chemicals or drugs, but that have much less toxicity. But there still are many cancers where the only approach is chemotherapy, but it is effective and it does lead to that cure. And so how can we deliver that and minimize toxicities is also one of the things we focus on.
All right. Well, we could talk to you for another half an hour, and I wish we could, but we appreciate your time. Thank you for being here and for the work you do. But that is all the time we have this week. Please remember, you can get past episodes of Behind the Headlines on the WKNO website at WKNO.org, or download the full podcast of the show from the Daily Memphian site, or wherever you get your podcasts. Thanks for joining us. Join us again next week.